It's the last of the live in a box cases, and I have the privilege and the honor to present it. I would like to thank Dr. Yakovo again, and I would like to show you how we treat ischemia in patients with no revascularization options. This is all about a male 76-year-old with persistent angina despite optimal medical treatment. Here you can see the major drug categories. The medical history, this patient had undergone CABADs with Lima and LAD in 1993 and multiple PCIs to Lima LAD to the right coronary artery and the circumflex. He had a preserved ejection fraction, arterial hypertension, dyslipidemia, and elevated creatinine. In his last coro, we really tried to fix left circumflex, but due to tortuosis and health calcifications, the PCI was failed. So our heart team, due to severe ischemia lateral and inferior lateral wall, suggested coronary sinus reducer implantation. So here you can see I'll skip this, the coronary angiogram, the left circumflex, healthy calcification, the patent Lima to LAD. Here is the wire. We really tried, but unsuccessfully. So here you can see the live in a box case, other ultrasound guidance. We go to the right jugular vein. We put a wire and then a 9 French sheath. And we start to try to get inside the coronary sinus. We use multi-purpose catheter, firstly. And then we exchange to AL1. Here you can see Dr. Yakovo in a not comfortable position, trying to access to the coronary sinus. And here we change with an AL catheter. Finally, we have managed to get to the coronary sinus. Here you can see the coronary sinus from the angiogram, and we're going to prepare the device, and we are going to use mother and child technique to advance the device. Here you can see we cut the proximal segment of the catheter, wire again, and then we advise the system. We advance the system here. The delivery sheath. Yeah, the delivery sheath. And now it's time for the occluder. Here you can see we are careful for major branches. We try to find the perfect position here. We prefer angiogram. And we implant the device. And we perform the final angiogram. Here you
So,
can see.
so how does this device work? Can you explain?
Yeah, give me. I have a slide for this. So here you can see our tools and some tips and tricks for the materials. I skip this. 1 year later, the patient was better in his symptoms, an improvement on his angina, and we performed right heart catheterization. We passed through the coronary sinus reducer, and we have some measurement here, approximately, and distal, there is a grade about 5 millimeters mercury. Experimental data showed an immediate mean gradient about 3 to 4. The grade is not huge, like in arterial stenosis, because excessive hypertension will risk venous congestion. And immediately after implantation, before tissue ingrowth, the pressure gradient may be smaller or not fully established. The physiological consequence: increased coronary venous pressure, increased capillary pressure, dilation recruitment of subendocardial microvascularized, redistribution of flow toward ischemic myocardial, especially subendocardium. There is a 2B indication in the European Society of Cardiology guidelines in 2024 in patients with debilitating angina and obstructing CAD refractory to optical medical and revascularization strategies. A reducer device for coronary sinus constriction may be considered to improve symptoms in experienced centers. Here's the greatest milestones in the pathway of reducer with the major trials. The major trials and evidence: COSIRA, Orbita Cosmic, COSIRA 2, Reducer 1, meta-analysis, etc. Pros: what with data support, symptom relief, and quality of life. Functional capacity gains in treatment time and 6-minute walk distance. Ischemia metrics: some studies show reduced ischemic burden, while CMR hints improve endocardial perfusion. Safety profile: high procedural success, low device-related complications. Unmet need population offers therapy for non-refractory angina patients. Cons: hard clinical endpoints improvement, no evidence yet for reduction in MI death or hospitalizations. Trials powered mainly for symptoms. Placebo effect: COSIRA effect showed a pronounced placebo response. Incremental benefit is real but modest. Imaging discordance: Orbita Cosmic signals subendocardial perfusion improvement without changes transmural perfusion. And heterogeneous responders: not all patients improve, predictors of response remain imperfect, and non-responders exist. Also, practical pitfalls consideration: patient selection, best for obstructive epicardial CAD, best evidence in history left coronary territory ischemia, anatomical and technical issues, need adequate coronary sinus size and accessibility, anatomic variants, Thebesian valve, tortuous can complicate delivery position, venous drainage and consideration. Be careful to prior cardiac resynchronization therapy leads. Expectation management: set realistic goals. Symptomatic and functional improvement is likely for many, but not guaranteed. No proven mortality benefit. Follow-up and authorization period means benefit may accrue over weeks to months. Optimize medical therapy and trial general ability. Take-home messages. For no option refractory angina, coronary sinus reducer has costed and evidence for improving symptoms, quality of life. Objective functional gains are modest but present. Patient selection, technical execution are key. Pending results from new trials will be important for practice refinement.
Thank you very much. That was very comprehensive. I did my first like 2-3 weeks ago, and I'm still waiting for the patient to improve. No, it takes some time.
Yeah.
I wanted to ask you a quick question to Yanis and to you, if you don't mind. Would the success, yes or no, of the reducer make you do less CTOs? Meaning that at some point, you guys, you do CTOs and you can really push the limit. Would you be more, conservative in your CTOs when you have an option that might work?
Well, we're a bit conservative in, it's our nature. But of course, it's a different thing. But we will have to accept that some lesions are not. We cannot treat them by doing. We cannot overtreat them. Like doing PCI, CTO recanalization, or maybe it's not worthwhile. So, but when we have all these patients difficult to treat with CTOs, especially after bypass surgery, and we have ischemia in the left coronary system, and you have not increased the pressure in the right atrium more than 15 millimeters of mercury. So this is a good indication for patient selection. So, patients that we shouldn't maybe try to recanalize. So this is the target that we aim for.
So you don't see it as a replacement for CT. Okay, good. That's an important message for all of us, I think. Do we have Dr. Kilic
Yes.
with us again?